Okay, so this is our primary and secondary hemostasis, and I'm going to go through kind of a foundation. Then I'm going to go through what the testing, in vitro testing, how it works in vivo, and then through some hemostatic disorders that we can have. So this sort of way that I go through the coagulation cascade and the primary hemostasis for that matter is based on a video that I saw by Dr. Adalik Adesina, and he's a human doctor, and that's the title and link to his video if you're interested in that. It's more detailed than I think you need to know, but he's also a lot funnier than I am. Okay, so we'll just start with this is our primary hemostasis. So this is how we form our platelet plug. So we have our endothelial cells here. Then when we have some kind of trauma that results in a break in the endothelial cells, we have this exposed subendothelial collagen and most importantly, tissue factor. So tissue factor is the most important thing that gets coagulation started in your body. So once we have that exposed tissue factor, then von Willebrand factor is going to be released from adjacent endothelial cells, and that attaches to the subendothelium. Also, you should note that in the blood, there's von Willebrand factor attached to factor 8, which sort of protects factor 8 in the blood. So that's something that may be relevant when you have a von Willebrand factor deficiency, and we'll talk about that more later. But that's what that represents there. So now we have our exposed von Willebrand factor, and then our platelets have a receptor called GP1B receptor that attaches to the von Willebrand factor and causes the platelets to become activated. So now our platelets are activated and spiky. And when the platelets are activated, they will release thromboxane A2 and ADP, which are going to recruit platelets and cause aggregation. And then it's also going to cause them to express the receptor GP2B3A on their surface, which is a receptor for fibrinogen. So now that we have that receptor, the fibrinogen is going to come in, and the GP2B3A receptors are going to bind to the fibrinogen, and then we're going to form this loose meshwork. And so this is your primary platelet plug. It's not very stable and it can be dislodged. The formation of this primary platelet plug is what BMBT assesses. So BMBT, which is your buccal mucosal bleeding time, assesses the ability to make this primary platelet plug, which is primary hemostasis, and that is all it assesses. Okay. So we're going to keep that kind of down in the corner there, and then we're going to talk about our secondary hemostasis, which is our coagulation factors and our coagulation cascade. So this is the way I sort of organize it. This is the way that I learned from the video, and that really helped me finally kind of keep it straight in my brain. So 10 goes in the middle here because it's very important. And then 7 goes down below. 10 minus 7 is 3. So that goes here. And then some other side factors. 4 is calcium, and 6 doesn't exist. So now we're ready to just count down left to right. So it goes 12, 11, 10's already used, 9, 8, and 8 is up here because it's a cofactor. 7 is already here, 6 doesn't exist. So next is 5, and that's also a cofactor, so that's up here. 4 is calcium, 3 is down here, 2, 1. So that's how I remember the order of my coagulation factors. And then when we're thinking about which one, so one of the pathways is this pathway that's long along the top. Then the other pathway is here. And then where they are the same, that's the common pathway. So 1, 2, 5, 10. And the way that I remember which pathway is which is, there's 3 things that I want to remember about each of these pathways. So one is which one's extrinsic and which one's intrinsic. So the way that I remember that is you can add 2 lines here to this and form the letter E. And so that's our extrinsic pathway. And then up here, you can add 2 lines only and make the letter I. So that's our intrinsic pathway. And then the next thing is which one is PTT and which one is PT. So I just remember that one. This one is much longer, so it has a longer abbreviation, PTT. And then this one down here is PT. And then the third thing that I like to remember is which one is first affected by warfarin and which one is affected more by heparin. And so this pathway here, the way that Dr. Adelig teaches it is it's shaped like a gun. Guns are used in war. So the extrinsic pathway is affected by warfarin first. And the reason that that happens is because factor 7 has the shortest half-life. So if you test PT and PTT early in warfarin toxicity, you'll only see a PT prolongation, but over time, they will have a PT and PTT prolongation. And so heparin is the other drug of interest, and so that one affects PTT much more than PT, and often we'll only see PTT prolongation if our sample is contaminated with heparin. Okay, and then the next thing is knowing some of the common names that are used interchangeably with the factor numbers. So fibrinogen, factor 1 is fibrinogen, and its active form is fibrin. Factor 2 is prothrombin, its active form is thrombin. The rest of them so those ones are used pretty interchangeably. I'd say most of the time people refer to them by their common names, not their factor name, but sometimes people will also call them by their factor name. So those are the only ones where you need to remember, like know the names for the inactive and active form. Factor 8 is another one that gets talked about a lot. It's anti-hemophilic factor A, and deficiencies in this cause hemophilia A. And then 9 and 11 have similar names. Deficiency in 9 causes hemophilia B, deficiencies in 11 cause hemophilia C, but those are just not very common in vet med, so you won't hear those talked about too much. Then factor 12 is Hagman factor, and you will hear people talk about that a lot because we see that in cats. And then factor 3 is tissue factor, and that is probably mostly only called tissue factor. Okay, then another thing that you just need to remember is that 2, 7, 9, 10 are our vitamin K dependent factors, and they make this nice little triangle here using this diagram, so that is helpful. Okay, the next thing that we want to know is what are our in vitro testing. So the first thing is PT assesses the extrinsic and common pathway. So it's going to go along this pathway, extrinsic pathway, and assess all the factors that are along this pathway here. So 3, 7, 10, 5, 2, 1. If you had a deficiency in any of those factors, then you would cause a prolonged PT. This is a test that's assessed on citrate plasma, and it's important to think about how these tests are actually run. So when you put your blood in the citrate, it stops coagulation. And then when you put the plasma in the machine is going to add to your sample tissue factor, it's going to add calcium back, and it's going to add phospholipids. And the phospholipids are like what your platelets provide, basically. So, even if you have a thrombocytopenia, that's not going to affect your PT because you're adding in phospholipids. So it's going to have as much phospholipids as it needs. It's going to have as much calcium as it needs. And then we add tissue factor to trigger the extrinsic pathway. So when you add those things, then coagulation proceeds along this pathway, 3, 7, 10, 5, 2, 1. So if you have a deficiency over here in the intrinsic pathway, that's not going to affect your extrinsic pathway. If you have a problem earlier in coagulation with your primary hemostasis, that's not going to affect your PT because you've added everything that the body needs to start at tissue factor and go to fibrin. The next one is PTT. So this assesses the intrinsic pathway along the top here and the common pathway. It also uses citrate plasma. So you put the blood in citrate, that stops coagulation. Then in the machine, it adds calcium, phospholipids for your platelets, and then negatively charged particles or glass beads. So this is just contact with a glass will cause the intrinsic pathway to proceed starting at 12 and going down 11, 9, 8, 10, 5, 2, 1. So only deficiencies or problems with any of the factors along the intrinsic pathway will cause prolongation of PTT. Another thing that assesses the intrinsic pathway that's like a bedside test is the activated clotting time, or ACT. So this requires that the patient's calcium and platelets are normal. The platelets have to be really low for this to, like, less than 10,000, I think, to cause a prolonged ACT. But just be aware that an ACT, it's a pretty crude test. It's only going to prolong if you have really severe deficiencies in any of the factors along the intrinsic pathway. And then the last one is thrombin time. So this assesses only fibrinogen function. So, let's say you have a factor, you have hemophilia A, you have a factor 8 deficiency. At this point, you have stopped coagulation in your, in your tube, in your citrate, and then you're adding thrombin. So if the body can't make thrombin because it's missing antihemophilic factor A or factor 8, that doesn't matter. We've added all the thrombin that we need to activate fibrinogen and make it into fibrin. So adding thrombin time only assesses whether you have sufficient fibrinogen or if it's working properly. So that's important to remember where these tests come in, and we'll talk about that more at the end when we talk about specific disorders. So the next thing is, how does coagulation actually happen in the body? It happens differently. So the initiation phase is when factor 3 or tissue factor combines complexes with factor 7, and that activates 7, 10, and 9. So then that's going to create a little bit of thrombin. So prothrombin is going to go to thrombin, and that's going to create just a little bit of thrombin. And then let's move up here. What does that little bit of thrombin do? It's called the thrombin spark, and it activates 11, 8, and 5. This is called the amplification phase. So then after our amplification phase, when now we have a lot more 10 than we had before through the extrinsic pathway. So 10 and 5 are going to complex and cause a thrombin burst. So now we have a ton of thrombin. This is called propagation. Now we have enough thrombin that we can now activate fibrinogen into fibrin. And then if we look at, remember in our primary platelet plug, we had our fibrinogen. And then once the fibrinogen is activated into fibrin, now we have fibrin, and additionally thrombin activates factor 13, which is fibrin stabilizing factor. So this causes the fibrin to cross-link. Now we have a very stable clot. And so that's kind of the end point of our coagulation. So once you kind of have this framework in your mind, then I recommend that you go to, there's lots of good videos on YouTube, but the one that I like is called Secondary Hemostasis, Part 2, Cell-Based Model of Coagulation. It's also linked in my link tree. And I think that will help you understand more like how it's actually happening in the body, like it's happening on the cells and on the tissue and on the platelets. And that's kind of what's bringing all these factors together. So it'll kind of give you a better idea of how this is happening in the body. So then let's just have this in our mind's eye. And we're going to go through some different disorders that you can have. So actually, let's back up and look at our platelets again. So the first one that I want to talk about is aspirin. So when a patient has aspirin, that inhibits COX-1 and 2, which inhibits the formation of prostaglandins, including thromboxane A2. And remember that thromboxane A2 is released, and that's one of the things that helps with platelet recruitment and aggregation. So if we don't have thromboxane A2, then our platelets are not being recruited. And so that's going to cause and increased BMBT, because this is our primary hemostasis is not functioning properly. We're not getting that primary platelet plug, but our platelet numbers are going to be the same, and this will have no effect on our PT or PTT or thrombin time for that matter, because this does not involve coagulation factors. Okay, so we'll go back to our kind of main diagram here. We have our primary hemostasis down here, and then our coagulation cascade. So a couple more with our primary hemostasis, a thrombopathy, similar to a patient that has been given aspirin. The platelets just aren't working properly, so they're not going to aggregate, and there's different reasons that can happen, kind of some different congenital problems or other diseases that can just cause a secondary thrombopathy, and that can be multifactorial. So they don't function properly, they don't aggregate very well, and so same thing as with aspirin, you have an increased BMBT because they're not aggregating and forming that primary platelet plug, but your platelet numbers are going to be normal, and your PT and PTT and TT are going to be normal because that your secondary hemostasis and coagulation factors are not involved. Okay, the next one is von Willebrand factor. So with von Willebrand factor, that's part of our primary hemostasis. And so when we have decreased amounts of von Willebrand factor, we do not have good binding of platelets to the site. And so we have an increased BMBT because once again, that's our primary hemostasis. And as I've been saying over and over again, defects in primary hemostasis do not affect your coagulation factors. And so your PT, PTT, and TT will be normal. But that's a little bit different with von Willebrand factor, because remember that von Willebrand factor binds to factor 8 in the blood. And so sometimes, not always, but sometimes when you have a von Willebrand factor deficiency, you can also have some, like a little bit of a factor 8 deficiency, because it's more readily destroyed when it's not protected by von Willebrand factor. So you can sometimes have mild increases in PTT as well. And then the next one is immune-mediated thrombocytopenia. So that's just a platelet number problem. And anytime you have platelets under 100,000, you're going to start seeing increases in BMBT. So there isn't really if you know that your platelet counts are really low, there isn't really a reason to do a BMBT at that point. And with immune-mediated thrombocytopenia, usually those numbers are really, really low, like a lot of times less than 10,000. So they're extremely low numbers. And so your platelet number will be low, your BMBT will be increased because of your low platelets, and then your PT and PTT and TT are unaffected because your secondary hemostasis is not affected. Vasculitis is also a primary hemostasis problem. Vasculitis can be all over the body, or it can just be in like one specific site. And so, you know, if you do a BMBT on the gums, if the gums don't have vasculitis, then your BMBT may be normal, but it is a defect of primary hemostasis that you have to keep in mind. So if you're seeing petechia in one specific area, but all your coagulation stuff looks good, it may be that you have some focal vasculitis. Okay, then when we're looking at our intrinsic pathway deficiencies, so let's just look at 12, 11, 9, 8. So those would all cause deficiencies in 12, 11, 9, and 8 would all cause a prolonged PTT and a normal PT and thrombin time as well. And then your because your primary hemostasis is not affected, your BMBT would be normal. So deficiencies in 12, 11, 9, or 8 would all cause a prolonged PTT and a normal PT and normal thrombin time. So the way that you would maybe, some hints as to what might be going on, factor 8 deficiencies are the most common of the hemophilias. So if you have a young dog or a dog that had, evidence of bleeding since it was young, then you might be more suspicious of a hemophilia A. although we can see hemophilia B and C as well. And then Hagman factor deficiencies are more common in cats. So if we have a cat that has no bleeding, then we're going to be suspicious of a factor 12 deficiency. Okay, next, if we have any deficiencies of things that are in the common pathway, then you can see that that's part of the extrinsic pathway and part of the intrinsic pathway. So we're going to have prolongation of both PT and PTT. So deficiencies in 10, 5, 2, or 1 are all going to cause prolonged PT and prolonged PTT. But because this is only affecting our secondary hemostasis and our coagulation factors, our primary hemostasis is not affected, so our BMBT is going to be normal. The one additional thing is with factor 1, where if you have a factor 1 deficiency or abnormal factor 1 that doesn't function properly, then you will also have a prolonged thrombin time. So our thrombin time gives our sample all the thrombin that it could possibly need to convert fibrinogen to fibrin. So the only reason that that would take longer is if you did not have enough fibrinogen or your fibrinogen was not functional. So thrombin time only assesses fibrinogen. And so with fibrinogen, also that's kind of an exception because it's also involved with platelet aggregation. You may see some increase in BMBT with fibrinogen deficiency, but not always. Has to be pretty severe. And then with factor 7 deficiency, you would only see a prolongation of PT, and your PTT would be normal. And then a couple other things with heparin, if I can get that to come up. There it is. So heparin enhances the function of antithrombin, which inhibits 12, 11, 9, 10, and thrombin, or factor 2. So heparin makes that antithrombin work better, and so you have increased inhibition of 12, 11, 9, 10, and 2. And this affects the intrinsic pathway more than the extrinsic pathway. So generally, with the amount of heparin that we're seeing in some of our samples, you'll only see a prolongation of PTT, but at higher doses of heparin, you can see a prolongation of PT as well. But typically, the reason that we're seeing heparin in our samples is because the syringe was the sample was contaminated with heparin, like they pulled it from the sample from a catheter or something that they just flushed with heparin, and then they drew a sample from it. So that's the most common reason that we see heparin contamination in our samples, and that usually will just cause a prolongation of the PTT. And then warfarin, so that's going to affect our vitamin K dependent factors here, so 2, 7, 9, 10 that make this triangle. So because 7 has a shorter half-life, the shortest half-life, PT will be affected first, but you can see that there are factors that are in the extrinsic, intrinsic, and common pathways that are affected. So you will eventually have prolongation of PT and PTT. And then with warfarin, there are a couple other things to think about, but in general, by the time they either, the owner knows that they ate warfarin, and so it's before they have any problems, or they come to you and they're already bleeding. So at that point, the PT and PTT are likely going to both be prolonged. Early, there can be a coagulative phase where you actually have increased coagulation, and so some additional things that you might see in that phase are increased fibrin degradation products and decreased platelets when you have sort of this massive coagulation and consumptive process of your platelets. But that's usually really early and not something that you all really recognize clinically very often. And then finally, just the last thing to think about is with liver failure, there's a lot of different things going on. So, whether they are throwing clots or having excessive bleeding just kind of depends on a number of factors because the liver is involved with a bunch of different things. So when you have liver failure, end-stage liver failure, your liver makes most of your coagulation factors except for factor VIII, which is made in endothelial cells. So you'll have a decrease in most of your coagulation factors, but you'll also have a decreased clearance of fibrin degradation products. So you may see some increases in fibrin degradation products just because the liver isn't working very well. But you'll also have a decreased antithrombin. So antithrombin is trying to keep your clots from happening, and you have this loss of antithrombin, or antithrombin is not being made. And so you can have increased clots, but you also have decreased production of your clotting factors, which are trying to make clots. So it's not always, you can clear what's going to come out of that. It just depends on the balance. And then patients with liver failure often also develop thrombocytopenia, and that's kind of multifactorial. So there can be a lot of things going on with liver failure that you may see with coagulation as well. But you want to be looking to your chemistries to get an idea if they have liver failure, and then that may like trigger you, oh, this isn't a primary hemostatic problem. Maybe I have liver failure, and that's what's causing my problem with hemostasis. So that's just kind of going through some of the defects. So hopefully this helps. This is kind of what helped me finally remember the coagulation cascade. And so I always kind of have this in my mind's eye when I'm thinking about different disorders, and if a certain factor deficiency would cause what it would cause prolongation of PT or PGT. And also remember to keep straight the difference between your primary hemostasis and your secondary hemostasis, and which tests specifically test for defects in each of those different parts of your hemostatic function. Okay, that's everything.